Hello, we're going to go ahead and get started, even as people keep joining us. Welcome, everyone. Welcome today to our webinar. This is the first in a two-part webinar series on funding and advancing equitable school-based substance use prevention and early intervention approaches. My name is Jessie Mandel, and I'm the National Program Director here at Healthy Schools Campaign. As part of our series for National Substance Use Prevention Awareness Month, we're lifting up schools' central role in prevention and early intervention. In today's webinar, we'll explore how states can shape their school Medicaid program to increase reimbursement for substance use services and supports. But this webinar is really part of a broader project, which includes 2 new reports and companion tools on the actions and approaches needed so that school-based substance use services are advancing equity for youth. Thank you all for joining us today. And for those of you that are putting your name in the chat, please feel free to say hello and introduce yourself. And we're so grateful, and I just want to acknowledge the many individuals who contributed to this project, who've shared their experiences and expertise with us. And this series was produced with generous support from the Foundation for Opioid Response Efforts, or the FOR Foundation. We're so appreciative of everyone, really so many people who have supported this project through their resources, through their time and insights. For those of you who are not familiar with Healthy Schools Campaign, it's great to see new people joining us. We're a national organization working at the intersection of education, health, and equity. We're based in Chicago, and we're a leader in advocating for sufficient and sustainable funding for school health services, including through Medicaid. Now, before I review today's agenda, just a few housekeeping items that I want to mention. First, this webinar is being recorded, so we will email out the recording, slides, and additional resources after. You can submit questions at any time. You can submit questions in the chat or in the Q&A feature. And the chat will, you can share comments to the whole group, and we'll do our best to answer questions throughout the webinar. And if we don't get to a question today, then we will follow up with you after. Now, on today's agenda, we will set the stage first with 2 speakers to talk about the importance of investing in school-based substance use prevention, and then discuss why it's such a key venue. School-based substance use prevention is so important to advancing equity. And then we'll look at the actions that states can take to remove barriers to reimbursement for substance use services, and then turn to a speaker from Colorado to see and share the innovative ways they are shaping their school Medicaid program to support schools and to support students. And then we'll have time for Q&A at the end. Now, for today, we're going to be talking a lot about Medicaid and school Medicaid. Medicaid, as many of you know, covers about half of all children in the United States, providing comprehensive health insurance, and it operates as a shared partnership between the state and the federal government. That's really a key piece of the Medicaid program. Each state has its own unique school Medicaid program, and today we're going to be diving into how states can shape their school Medicaid program, but we know the school Medicaid program is complex. And if you'd like to learn more about it and have more questions about kind of the foundational elements of school Medicaid, please check out some of our previous materials, including a webinar series we did last year that really talks about kind of the foundational elements of the school Medicaid program. So now I'd like to introduce our first speaker, Allison Sutter, Senior Program Officer at the FOR Foundation, to share some remarks And Allison comes to us with just a breadth of experience in this area. She's developed harm reduction initiatives and has overseen affordable housing programs to support comprehensive and supportive services. And we're so thrilled that you could join us today, Allison. Thank you so much for being here.
They're so glad to be here with you all. My name is Allison, and I'm the Senior Program Officer at the Foundation for Opioid Response Efforts. And many thanks to the Healthy Schools campaign for hosting us today. The Foundation for Opioid Response Efforts is a national grant-making foundation, and we support innovative solutions to ending the opioid and drug overdose crisis in the United States, including work to expand evidence-based substance use disorder prevention and early intervention services for students and young people. And we've been very proud to partner with the Healthy Schools campaign to explore and amplify pathways for Medicaid to fund school-based substance use prevention services. So in recent years, we've seen concerning increases in youth overdose deaths, as well as increased rates of mental health concerns among young people. And the ongoing substance use and overdose crisis in the United States leaves youth vulnerable to adverse childhood experiences and intergenerational trauma that can increase the likelihood of substance use disorders later in life, in addition to a range of other health and social concerns. And even when we do see promising trends like overall decreases in substance use among young people, we still see racial and socioeconomic disparities in those successes. So it is critical that equitable solutions to the concerns of youth substance use and overdose have sustainable funding to ensure better outcomes for young people and their families, particularly in schools who are uniquely positioned to provide impactful prevention and early intervention services. And Medicaid is a promising source of funding to support school-based prevention services. This is a very opportune moment for this conversation as states look to open up new flexibilities and expand the range of services and providers that can be reimbursed. So with that in mind, we're very grateful to the Healthy Schools campaign for their analysis and guidance to support schools in maximizing school Medicaid for substance use prevention, early intervention, and treatment. We're seeing in our work that states and school districts are seeking guidance and collaboration to navigate these funding pathways. And the Healthy Schools campaign and the experts on this webinar are here offering the resources and shared learning opportunities that are needed to expand access to healthcare and funding. So thank you all for being here today, and I will turn it over to the rest of our presenters.
Thank you so much, Allison. And I will now introduce Kima Joy Taylor to talk just a little bit more about the importance of advancing equity through school-based substance use prevention. Kima is part of the project team and also founder of Inca Consulting, and she's an expert in many areas, including policy and programming to improve equity, integrate behavioral health and primary care and social services, and support developmentally and culturally and linguistically effective holistic healthcare. Kima, so much for being here.
Thank you. And thank you so much for having me. I'm honored to be here and really was excited about the project as a whole when it started, and really want to thank you for having the faith in us to get this through. But, you know, I wanted to have a conversation around substance use because I often notice that the country and schools and others would often talk about mental health. And say, well, substance use was included, but as you drill down, wasn't, or they weren't sure how to include those strategies for myriad reasons. And I think we all know that youth well-being, holistic health would include a continuum of substance use services that include prevention and early intervention as our society is moving forward, and as Allison mentioned, is in the midst of an overdose crisis. So I know that, you know, we knew Healthy Schools campaign was doing great work in understanding how to really take advantage of the unique position of schools. Kids are in schools for so often during the day, often whether it's a teacher or principal, they may have a trusted source there. And so taking that unique position they hold, the newer interest in really understanding how to promote health and well-being in students, wanted to make sure substance use prevention and early intervention was part of the picture and part of the conversation. Now, challenges exist, and this is really important. We hope you come to our next webinar next week. And those challenges include sustainability and ability to sufficiently fund these services. But you don't want to fund something that's not going to be effective, right? And so we need to ensure and work to make sure funding goes towards those programs that are truly going to see equitable outcomes, outcomes regardless of your race, your age, your disability, ethnicity, primary language, sexual orientation, gender identity. We want all of our kids to be well. And so how do you think about doing programming that will allow for that to happen? And we have some conversations around that in the next webinar. And so we hope that you join us next week, but I'm really excited because as schools vary in their implementation, as they're doing this work, as Allison said, they really do need to be funded sustainably and repeatably. And so I'm excited that this conversation has happened and that Lena and the team have done this deep dive.
Thank you so much, Kima. So now let's dive in to just that very question of how states can do this. And as Kima said, we will explore more next week, but today's conversation is really about how states can maximize the funding to do this work. And I'm so excited that Lena is here to dive in with us. Lena O'Rourke is also on the project team and consultant Healthy Schools campaign, as well as founder of O'Rourke Strategies and a school Medicaid expert extraordinaire. So Lena, thank you so much for walking us through this report, and over to you.
Thank you, Jessie. And thank you all for the opportunity to present today. As Kima said, I do think that this is a really nice opportunity to lay some groundwork for what you'll hear in the second part of this series next week, when we're really talking about the programmatic pieces of preventing substance use. My job today is a little weedier and to think about the sustainability and the financing pieces. Next slide, please. And specifically, we're going to be focusing on Medicaid and how Medicaid can be thought of and leveraged to really help pay for school-based prevention services. So prevention, early intervention, and treatment services. But really, what does that mean in a school Medicaid context? And how can we think creatively about creating a school health infrastructure that really supports school providers in delivering these services? And where I want to start is with the fact that Medicaid pays for services in schools. And we're not going to do a lot of Medicaid 101. Jessie referenced our webinar series from last year that gets into it. But I want to level set with a few really important foundational points, which is Medicaid pays for services in a school if that student is enrolled in Medicaid, if the service is covered by the state plan, which is quite broad, and then if the provider is a qualified Medicaid provider. So there are some rules in how it works, but Medicaid pays for services in schools. It's really going to look different depending on what state you're in, and we'll unpack that a little bit together here. I do want to upfront just really home in on the fact that everything that I am going to talk about is focused on district employed providers and how they are paid in a school. So the school nurses, the school psychologists who work for the school system. Other types of providers like community, school-based health centers, like community health providers, they also deliver services in schools and are a huge part of the delivery system, but they are paid a little differently. So what I'm talking about is really the district employed providers through Medicaid. Next slide, please. And so we're going to tick down a little deeper then into what Medicaid could pay for in terms of substance use services. And the new federal guidelines around school Medicaid are explicit that these types of services are permissible under federal Medicaid. Substance use services that are provided in the school are reimbursable by federal Medicaid. So schools are already delivering substance use services. And next week with Kima, you'll think a little more creatively about what those services should look like. But we know that some services are being delivered in the schools already. And if they're not being reimbursed, That's just leaving the federal dollars on the table. So creating this infrastructure in the state is what we're going to talk about and dive a little bit more into. Next slide, please. About how you would make state policy choices to bring down that money. Because I'm sure some of you are thinking, wait a second, you're telling me that Medicaid pays for school health services, including substance use, but my school isn't getting that money. My state doesn't pay for this. And that might be true. It looks different in every state, but it can. And your state policy choices make that difference in partnership with the federal guidelines. And there are challenges. This is not the easiest policy to get through. You need to create policies that support prevention and early intervention. You have to bring the school districts into the school Medicaid program. And there are challenges with that. It's hard to do, but not impossible. But it is tricky for the small and the rural districts. You have to think about the administrative burden on school providers and administrators and what that looks like. Again, these are solvable problems through state policy and through the application of best practices, but they do have to be, care has to be paid to set the state policies in place so that you can take advantage of that federal money that is otherwise being left on the table. Next slide, please. So what we looked at, all of us at Healthy Schools campaign, is what does the state actually have to do here in terms of school Medicaid? What are those things you have to do to create the state policy ecosystem? What are the levers a state can pull in order to really more effectively remove barriers to reimbursement for substance use services, including prevention and early intervention? I'm going to tick through those a little bit more now, but we came up with 10. I'm not going to go into a lot of detail. We can do that in the chat, but let me tick through a couple of them to really set the stage for a deeper conversation. You'll hear this from Shannon after me about what it looks like in practice. So next slide, please. So the first thing a state needs to do to be able to really take advantage, for school districts to really take advantage of the school Medicaid program, is to make sure that all students are reimbursed, are included in the school Medicaid program. Historically, only those students with IEPs could have their health services paid for by Medicaid in a school. By taking advantage of what is called the free care policy, states can bill for the service, be reimbursed for the services to all Medicaid enrolled students in their district. We do have a map that shows the state decisions, and we link to that here. That will give you a snapshot of where in the spectrum your state is. Have they done this yet? If not, this is a policy that helps bring in more federal reimbursement for substance use prevention services. Next slide, please. Next, to Kima's excellent point, states need to provide guidance on how to make sure the right services are delivered, and really focusing on culturally and linguistically effective and evidence-informed services. What are those services that work? What is the mechanism to get those paid for in schools? And you'll hear from the team on next week's webinar more about what that would look like. And we encourage state policymakers to really make explicit guidance about how these services can be delivered, what works, and how they can be reimbursed. Next slide, please. And related to that, it's important that all medically necessary services be covered in a school setting. This is a feature of Medicaid, that the services do need to be medically necessary. But there is the statutory authority under a benefit called EPSDT to cover all of the medically necessary services in schools. But some state plans cover a narrower set of services. So it does require changing how Medicaid operates in the state, but by covering all medically necessary services, you open the door to the maximum coverage of substance use prevention and treatment services. Next slide, please. Then once you've done that, once you've set the groundwork, that all medically necessary services are reimbursable in a school. We advocate that states really prioritize prevention and early intervention and set a state policy framework that has clear guidelines for covering substance use prevention in addition to screening and treatment, and provides the necessary infrastructure and support to schools on how to bill for those services. What does that look like? How do the medically necessary standards apply to prevention? Under what circumstances can prevention be paid for? It's a tricky thing to do. And states are really exploring what this looks like, which gives a lot of room for creative thinking on answering questions around prevention. I would also like to highlight the importance of covering services before a plan of care is required. For Medicaid, in most states, a formal plan of care, a written plan of care, is required and is the best practice for delivering the services. But we acknowledge for prevention, for crisis intervention, for a range of services, it doesn't make sense to have that plan of care in place. So what can a state do to help with those services, either while the plan of care is being put in place or in advance of it? So thinking about those things in terms of how your state deals with that already and how you could push the envelope is an important part of this puzzle. And again, I'm not sure we've entirely cracked the nut on how to do this, but I think that is where states and state policy are moving, and it's really exciting. Next slide, please. So this next one is a little technical, but super important for thinking about how substance use services are delivered in schools. So in schools already, there's a wide range of providers who deliver services. They're licensed or credentialed or whatever the state requires under the Department of Education to be in the school, and they are highly qualified providers. And they work in the school delivering services, whether that's prevention, whether that's classroom intervention, they're there delivering the services. And then over here, you have the Medicaid qualified providers who are authorized to be reimbursed under the Medicaid state plan. And the problem exists when those two lists don't line up, because you have school providers delivering health services that are not reimbursable because they're not qualified Medicaid providers. And we think a lot about this in terms of some of the non-medical providers who deliver medical service, non-medical services under Medicaid, a lot of the prevention work, what that could look like. So one thing a state can do is align those two sets of providers. So the list of providers who's already in the schools or who we want to be in the schools, making sure that they are able to be reimbursed under Medicaid is an important way to maximize the federal reimbursement coming in. Not easy, it's not easy to do, but it is solvable and a really good way to start this conversation by looking at the providers who are in the schools. Next slide, please. Then there are a whole bunch of administrative things that need to happen, and administrative infrastructure to set up your school Medicaid program for success. That includes minimizing the documentation requirements to the extent possible in the state to relieve the administrative burden on the school-based providers. It includes setting up and working with a Medicaid administrative claiming program, which allows schools to be reimbursed for certain functions of administering the Medicaid program, including outreach and enrollment to get the kids and their families enrolled in Medicaid. And then really thinking about how Medicaid finances and supports the entire school Medicaid, and in fact, the entire school health infrastructure, and thinking about reinvesting the federal Medicaid funds that are coming in to broaden the package of services that are offered and reinvesting those services in particular into substance use prevention. and how that could be done. Next slide, please. And look, I get very excited about thinking through these challenges and creating this infrastructure, but it is hard. And what is most exciting, I think, about this moment is how state Medicaid agencies, state education agencies, public health departments, and school districts are partnering with each other and, importantly, with families to think about how to transform the infrastructure in the schools and are really tackling some of these hard problems. So building stronger coordination between the organizing bodies is important. Thinking about some of the challenges, the structural challenges of Medicaid, that Medicaid typically just covers evidence-based clinical interventions. And we're talking about a model that is the opposite paradigm of prevention, of early intervention, of culturally and linguistically appropriate services in the schools. How does Medicaid shape around that to really lift up the students in the schools? The challenges I talked a little bit about already about non-traditional medical providers and how to get them reimbursed in the schools, and to how to bring in the right type of providers and to make sure their services are sustainably paid for so that they can remain in the schools. There are challenges in the education setting because certain providers can never be certain people working in schools will never be Medicaid providers, such as many teachers cannot be a Medicaid provider. But how do we recognize and acknowledge the important role they play in creating a healthy school environment? So I acknowledge that these challenges are tricky, but I offer some hope, and I'll turn it over to Jesse as soon as the sentence is over, so we can think about this from the state angle. States are really working on this and plugging in the teams and building the collaboration to move it forward. So it's a really exciting moment to look at all of these 10 levers and these challenges to see how we can move things forward. So Jesse, I'll pass it back to you to go forward.
Lena, thank you so much. That was awesome. And please put questions in the chat. I see some coming in, or questions in the Q&A, because I almost want to go back. Can we go back just to that chart slide one more time as I'm introducing Shannon, just because I think what you laid out is so, yes, this is the one, thank you. And so here are kind of all the things together one more time. But Lena, what you laid out is so helpful, and I'm really very excited now to have Shannon Huska here to share the perspective of what they're doing in Colorado and how they're kind of thinking through some of these boxes. And Shannon Huska has really been a leader in the school Medicaid space, and not just a leader in Colorado, but nationally, pushing the envelope, providing very innovative and creative thinking around what states can do and how they can best support students and schools. Shannon Huska is the Financing Deputy Division Director at the Colorado Department of Healthcare Policy and Financing, and she oversees a variety of payments and programs, including the School Health Services Program. So Shannon, thank you so much for being here, and looking forward to learning more from you.
Thanks, Jesse. And I am probably going to echo a lot of what Lena said, but kind of just expand more on what we're doing in Colorado. So Colorado has taken steps to really increase their program, and as a result of that, it's helped leverage substance use and prevention and early intervention for those services. So some of the things we've done is, as Lena referenced, the free care reversal. We expanded our program back in October of 2020. We were slow to kind of start to the expansion, but when we did so, we wanted to make sure it was the right thing to do for all of our districts. And when we expanded, obviously expanding in October of 2020 was probably not the best time to expand, but that's when our state plan was approved for and we moved forward. But what it meant for us was that not only were we able to expand outside of IEP services, we were able to expand to all those other plans of care where medical necessities established, but we also wrote into our state plan for where medical necessity is prevalent or established as well. So it doesn't necessarily have to be on a medical plan of care. Another thing that we did is we wrote our state plan in such a way that when we want to make changes to our program or when changes happen with our Medicaid agency and providers are expanded, we don't have to open up our state plan every time for those pages that are specific to the school-based Medicaid program. So we mirror essentially our overall state plan. This allows us to make real-time changes if a provider is being added statewide or services are being added statewide. We have the ability to continue to add those providers and services to our list of qualified providers or allowable services. One thing that we also did too is we worked hard to align the providers, as Lena was mentioning, to those qualifications that are at the Department of Education in Colorado. Because they, as she said, they don't always align, right? Our biggest hurdle was school psychologist. School psychologist is very specific to the school setting and not the Medicaid world. And we had to work with CMS. It took us an additional year or more to get that approval, but we worked with CMS after we expanded for free care to ensure that we could get school psychologists also listed on our roster and claim those costs and those services, which does help with the substance abuse disorder services as well. It really expanded all of those codes. And in addition, in the last year, a new bill was passed that went into effect July 1 that really expanded a lot of those mental health, behavioral health codes in Colorado, made them mandatory, also required us to expand some of those codes. So all of these things together really helped in expanding the substance use and our program in general. One thing that Colorado does that's a little unique, I know there's a few other states out there that do it, but it was actually written into legislation that the school health services reimbursement, the federal dollars that go back to the school district, they have to, it's not an option, be reinvested into health services for all students. It doesn't mean it just offsets the special education services when it was just IEP or just the services that we cover. If it's health related and community input says that this is what needs to happen in a school district, Colorado will, it has to the reimbursement in Colorado has to go back to health services. Sorry, I stumbled on my words there. But it makes it really nice. And we know that when we send the federal dollars to a school district, it's not going to go to buying a new football field or whatever it may be. All things that are important for schools, but the health and well-being of our children is also super important. And we know it's going to go back to that. The school districts have to develop what we call a local services plan with community input that designates how these reimbursement dollars are going to be spent. And it has to be approved by the Colorado Department of Education, and we review how they actually have spent the reimbursement dollars every year. The two main categories that have been, and I don't see changing anytime soon, that reimbursement dollars go to are mental and behavioral health services and nursing. And we don't have a separate substance abuse disorder category, but those are the two categories that they would put any of those services in there. I spoke to my colleagues at Department of Education if they had any more specifics on what services or what substance abuse disorder related services that their schools are reinvesting in. And, you know, some schools have used the money for tobacco and vaping use prevention training. They've sent coordinators to reducing student use of substance conferences, different things like that. So we know the money is going back into this area, and I expect it will only grow as this topic becomes more and more prevalent and more of a hot topic in all of our states. What else? I think, one of the recommendations I have, and what we really did, and Lena referenced this earlier, is our communication and collaboration with all parties was really, really key in expanding our program to not just be IEP services. We had a very, very strong stakeholder engagement through the whole process. And I have been on these before. I've talked about our process. It was quite lengthy. It took years and multiple phases before we decided to move forward with expanding for free care. But in that process, we gained the trust and the backing of our districts, Department of Education, and Medicaid agency all work together on it. And I don't know that we would be the program we are today if we did not have that collaboration. We have strong stakeholder meetings still to this day and are continuously looking at ways to improve the program, how we can reinvest. We're looking at best practices. We are developing some tools that will highlight some of these unique situations where money is being reinvested to give other districts other ideas on ways they can spend their reimbursement money. And some of the challenges too is staff. I mean, I think that's a common known one, right? The staffing is not there, and the funds are wanted by all. Like Medicaid is a small portion of school districts reimbursement, but we are trying to ensure that when the reimbursement does go back in, it goes to those services that are really needed and at the forefront right now. I think that is the majority of what I have. I'm looking at my notes. But again, it's such an important area, and, happy to answer any more questions about the specificities of Colorado's program and how it relates to this topic. Lena, Jesse, did I miss anything that you got?
No, but I think, Shannon, that was awesome. Thank you so much. Like I was taking notes as you're writing. What we're going to do now is have a Q&A, invite Lena back up too. Lena, you will probably be asked questions and ask questions. So in all the roles, but and at this point too, please feel free to put questions in the chat or put questions through the Q&A. And also, Lena's been furiously answering questions in the Q&A. If you have like a follow-up question to your Q&A question, put that in too. This is really, I'm really excited for this part because I think this is where we can keep building off of what you shared, Shannon. I think I'm going to just kick it off with a very kind of blanket statement, and then we'll go into some of a blanket question, kind of a generalist question, then we'll get into some of the specific ones that I see in the chat. But Shannon, I'm kind of curious what you would say to states if they're just getting started. What would sort of be the first place that you would say, and what's kind of the first starting point that you'd suggest?
For just starting a school-based program, or
to try and maximize the reimbursement first, substance use, behavioral health.
I mean, I think maximizing the reimbursement, the first place you really have to start is your state an expanded state? Yeah. Have you expanded for free care? And have you expanded fully? Like, do you know that you have expanded all the different service provider types that you possibly can? I know we're taking yet another look at it just to make sure, but we feel like we're pretty much hitting all the things. The school psychs was probably our hardest hurdle, but really looking at those areas and getting buy-in from all the different groups. That is huge. If you don't have that, you're just going to be up against a brick wall.
Yeah. thanks for that. Yeah, I think, and it's really amazing to hear about the work that you all did and have continued to do to build that buy-in. Turning to some of the questions in here, I wanted to ask you specifically about ESSER. And is that eligible for Medicaid reimbursement? Are you all covering ESSER in schools?
I need to defer
Okay.
back to you. I believe that's funding, and we would not be able to use that for Medicaid funding.
ESSER.
I think that's pretty consistent with what we find across the country is there hasn't been a lot of take up on covering ESSER or other tier 1 prevention screening programs. Again, I said this before, I'll say it again. I think this is the next big challenge for all of us, is to really think about, particularly in the mental and behavioral health space, how some of those tier 1 services are reimbursable, and then what the state has to do to get there. I think it's that mismatch between the services that are actually being delivered in schools, maybe with other funding, and which of those services could be paid for by Medicaid. So, so my short answer is and please, I would love it if somebody corrected us in the chat and somebody is paying for ESSER. Oh, and look, Massachusetts. So we can lift that back up, but I think a lot of states haven't figured out how to do that yet. Thank you, Emily.
Massachusetts is covering ESSER as behavioral health screening when performed by a school nurse or school counselor psychologist of other qualified behavioral health provider. Just reading Emily's response. But I think, Lena, what you're saying too is that, and Shannon, what you started to get to with reinvestment, I mean, also reinvestment dollars could go towards some of these prevention services. And I think that's also really key. I actually wanted to lift up the question that Logan had in the chat too, which, because I think your reinvestment model is so fascinating what you all are doing. And Logan asked, in Colorado with the reinvestment funds, is there a funding methodology to share amongst all school districts, or in the funds that are reimbursed for specific school districts, or are the funds for specific school districts going back to that specific school district? I kind of butchered that question, but you got, you know it. Yeah, but I think that's really interesting. How does that work? How does that funding go back to?
Right. So, Logan, to answer your question, yes, the money goes back to the specific school district. We have a methodology. We're a certified public expenditure program, which is key, which our methodology, there are some components of it that are district specific, and then there are some components that are statewide. Like our time study percentage is a statewide percentage. The Medicaid enrolled rate, though, is a district specific percentage, and salaries and benefits, those are district specific. So it really kind of depends. Your reimbursement is dependent on your district as well as the state as a whole, but we do reimburse by certified public expenditure. So it's not just here's a pot of money, let's just disperse it evenly amongst 50 districts. We disperse it accordingly, according to the methodology. And there is no set bucket because it is certified public expenditure. There are expenses that have already been expended. We do reimburse interim payments in the year as we're waiting for, so that cash flow keeps going throughout the year. And those are based off of prior year's cost reports. And so we just basically pay 1/12 of what we assume their costs are going to be each month throughout the year. Hope that answers your question. And if you have more, please let me know.
And do you know, oh, and thanks, Shelley, for sharing what South Carolina is also doing around behavioral health screening and ESSER. Shannon, just to kind of follow up on that, Margot had a question in the chat about what's the history of on how Colorado put that into place, because it's unique. Most states don't do that. So what was the impetus behind saying that the funding should go towards school health services?
It goes back to before my time when we first started the school-based program. It goes back to 97, I believe, when the legislation was passed saying we needed to start a school-based program, and advocates and community partners who were working on the legislation wrote that into the legislation.
That's great.
That's the short answer of it.
Yeah. No, that's interesting, and it's, yeah, that's interesting to hear. I have a question that came, not through the Q&A, but I wanted to lift it up, just around, for people that are just joining today, and either one of you can answer this question, but, where do you kind of suggest, so the question is, where can we kind of learn more about what's allowable in our state? We currently add our services for health histories for IEPs, medication administration, hearing, and vision. But I feel like there's so much more we can capitalize on that we are missing. So, and maybe other people feel, that's why I wanted to lift up that question, because there are likely other people on the call who might be having that similar feeling.
So I can start, and then Shannon, I'll have you jump in. So here's how I think about, I mean, and we can go back to that chart in my slides about all the different things that could be done, and really looking at what's happening in your state now, because I think, like Candy's question implies, there's probably so much more that can be done. And, you know, even Shannon in Colorado, who is a leader here, is going back and looking again to see what else needs to be covered. So, you know, the question of is fundamentally of where do we start? Like, how do we do this? And how do we maximize this program? So I think one of the best things either the state or the school district can do first is take stock of what's actually happening in schools. Who is in the school delivering health services? Who do you want in the school delivering health services? How are those services being paid for? Who are the kids who are getting those services? How many Medicaid kids do you have in your school district? All of these sort of foundational pieces of information help you get closer to the gaps in what your program covers. If you're in a state that has not yet expanded under free care, you're only paying for services in an IEP by definition. So all the services for the general education students covered by Medicaid are not being paid for. And so looking then, take a stock on what's happening in your schools, then what is Medicaid paying for is the second step, and really looking at, does your district participate in Medicaid to begin with, because many districts do not. If you are, which services are you getting reimbursed for? And then do that crosswalk between the services that are being covered in your district and the services that are being paid for or not being paid for by Medicaid. And that's your growth area. And so by getting all of the kids wrapped into the Medicaid program, you expand beyond just the students with IEPs to all the students in general ed as well. By looking at all the services that are not being reimbursed, you know, you have a sense on what the state plan needs to either change to do, or maybe it's actually at the district level and you can just quickly change your district policy, change your district policies to be able to reimburse for that. The same question about the different types of providers, looking at the crosswalk. So it takes a little bit of elbow grease to write all of this down. It certainly takes some dedication and some teamwork. It takes having people at the school district level who really understand both the student health services and the billing side of it, and the state people. I mean, that's why, you know, I think Colorado has been so successful, is you had all of those players. A lot of states have great teams of people already working on this together, and it's really just building on that. But I think that's how you capitalize. You figure out what you need and then what that obstacle is. Shannon, does that track with?
Yeah, I would say it absolutely does. And I would just add that, you know, after you've done that crosswalk of what's happening in the school and what Medicaid pays for, I think it's also important to go back and look at what does your overall Medicaid pay for? And those are kind of like your low-hanging fruit if you're not reimbursing school districts for some of those services, because you should be able to get approval for those types of services fairly easy if your overall Medicaid providers in the community already are doing these services or are qualified providers and you're not reimbursing school districts for them. So kind of also taking that crosswalk a step further of what does your school-based Medicaid program cover versus what is your overall Medicaid state plan in the community cover too.
And I think I want to just also mention somebody answered it, but about what to do if your school district isn't participating. And Shannon, I'm kind of curious what you would say to that if your school district just isn't participating, expanded state or non, in the program overall.
I mean, we've dealt with this for years. We have 178 school districts in Colorado and about 60 overall participate in the school-based program. Now in Colorado, that means 85% of our total student population is covered under those districts, but there are still districts out there who could benefit, right? We do a cost benefit analysis for those districts. We do a lot of outreach. We work hard with them to ensure, like, look at their situation specifically and give them an idea of what that reimbursement might look like for them. You know, it's not going to be exact because we don't have all of their numbers, but we do some statewide averages and different things to come to those. And we try to be conservative so that we're not overinflating what we think they could get. And then that district then has the information to determine if for them it is cost beneficial to participate or not, because it varies from district to district. Some districts, you know, they have 100 students, and that's a true thing in Colorado. Like, there are districts that have very few students, and if we say with, you know, this much work you can get $5,000-$10,000 a quarter, they're all for it. And then there's some districts that are like, yeah, that is not worth my time and energy, and that's totally fair too, just because of the small population. So we really work with districts, and we have before we expanded, and that's a recommend for states to have some sort of mechanism to allow districts to have an idea rather than just, yes, sign up, you'll get money. You know, it doesn't always work well. There is work involved with the program.
So in a way, also it's reaching out to your state school Medicaid person. Ideally, you know, it's finding the best person to reach out to in your district too, and that does vary state by state, district by district. But I think if there's starting with your Medicaid agency is a great way to start, and maybe working backwards from there. Yeah. And we know that I mean, again, it's Colorado's amazing, and we know that not all states have somebody that's championing this in their state agencies, and we hope all states at some point will. But also that's why I think it's important for the Medicaid and the state education agency to have resources available, so that school districts that don't get started can go to either entity to look for this as well. As we're coming to an end, I just wanted to lift up a question in the Q&A. It's about a specific question around whether a provider is qualified, and that might be a little bit more in the weeds and specific to the state. Around I'm an RN BSN currently working with a special needs unit as a nurse paraprofessional. Am I considered a qualified Medicaid provider under my personal license? And so I think you could kind of, if you want to weigh on that, you can, Shannon, but I'm also wanted to just get to the question about what roles can I suggest to our rural school districts that facilitate this school-based program, because we know that the challenges that rural schools are facing when it comes to substance use are great and can vary differently than what urban schools are facing. So I did want to hear your thoughts on kind of the rural piece too.
Well, let me tackle the first.
Okay.
Tackle the rural piece, which is that the specific types of providers and the qualifications necessary to be reimbursed by Medicaid are going to vary dramatically from state to state. So the best answer to your question will lie in the state and in the school. But I do just want to say that some of our best and most dedicated school Medicaid champions have been SPED providers, been the nurses, been the paraprofessionals. Some of our real rock star transformers of the school Medicaid program over the years have been individual providers who either weren't covered as Medicaid providers, but saw how much their school district needed the money and the stable, sustainable financing as grants shifted, and have advocated for it, or seen, their districts with so many Medicaid enrolled students not fully able to leverage the program, which again would bring in more federal money. And those nurses, those paraprofessionals, those educators were the ones who have transformed these programs. So figuring out what your status in the state would be is state specific, but I offer it as a real opportunity to both find out the answer to the question and then to launch off of it. But Shannon, what would you say about the rural piece?
I mean, rural is always a challenge. We often, so in Colorado, we have boards of cooperative education services, and that is used more specifically in rural areas. It is a group of, varies depending on we call them BOCES. It depends on the area. It's a group of districts that share special service providers. And so instead of one district having to employ one PT, one OT, one SLP, the group of districts, say 5 to 10, could share that so they can employ full-time employees. That we find works really well. So in Colorado, instead of going after those individual districts to participate in the program, we go after the BOCES and get the whole collaborative together. But rural is always a challenge. It's harder to get providers. We have some very small rural areas in Colorado. We do support telehealth as well, and we'll reimburse for that, which is another mechanism to get some of those services in the rural areas, but always looking for new ways to get services in rural areas. And we don't have it totally figured out yet.
Thank you. Thank you so much, both of you, for this conversation. I know we're at the top of the hour, so I'm going to close this up, but I just really, really appreciate Lena and Shannon for this conversation, for your expertise, and just that, and everything that you're continuing to do to keep building on the amazing foundation that you've already built in Colorado. So thank you so much. We can put the final slide up that just has our information about the next upcoming webinar. These are the resources. Of course, we'll share these out. So please join us next week. We will have part 2 of our webinar series, and that's when we will explore strategies for advancing more equitable and culturally and linguistically responsive services in schools. So piggybacking off of everything that we hear today, as you're maximizing these sustainable funding streams, how do we make sure that we're advancing equity with that funding, and supporting a real continuum of school-based substance use prevention, intervention, and treatment measures in partnership with youth and their communities? So please do join us next week. We'll have a great panel discussion. And thank you so much to Allison, to Kima, to Lena, to Shannon, for just the incredible discussion today and everything that I've learned. I hope you all learned a lot, and please reach out to us anytime. We're here to help and want to be a support however we can. So thanks again, everyone. Have a great rest of your afternoon, and hope to see many of you again soon. Thanks.